All right, so week 5 or unit 5 in pharmacology covers chapter 54, which is anemia. There's a little bit on the hemopoietic growth factors on pages 751 to 753, which is found in chapter 47. And I noticed that all of outcome 1, hemophilia, isn't even in the reading. And so I just double checked on the quiz, and it is not on the quiz, so that's good. Hemophilia is covered in a very small manner in chapter 26, but we did discuss it a little bit also in P&P. So I'm going to touch on it briefly, but it's not on your quiz, so don't spend a lot of time looking for the outcomes for content 1, A, B, or C. Focus your reading on chapter 54 and then just those short pages 751 to 753 on the hemopoietic growth factors. So hemophilia itself is just a rare genetic disorder where there's some abnormal clotting factors that are either limited or absent. And this means that when the patient sustains an injury or has, even just like a small cut or defect in the skin tissue or a vessel, the normal clotting cascade can't be activated. So if you look on page 413 in your book in chapter 26, it shows you part of the intrinsic and extrinsic, the pathways for clotting. So how clotting is normally activated and the different factors that are involved in that. Anyway, there's some different types. We usually talk about hemophilia A and we talk about hemophilia B. Factor 7 and 8 is A and factor 9 is B. Factor 7 and 8, hemophilia A is the most common, and then factor 9 is more rare. And then there are some other ones that make up a very, very small percent of other hemophilias. And then there's some other types of kind of hemophilia related or clotting disorders, related clotting disorders like von Willebrand's disease, and that also is related to factor 8. So, again, not on the quiz, don't spend a lot of time on it, but it's in the outcomes, and obviously that needs to be updated. So what do we do if somebody gets injured and they have hemophilia? So as I mentioned before, even if they have like a small laceration, like a kid falls and they put their teeth through their tongue, or they have a small laceration to their lip, or even, like they crush their finger and they have an open area where the bleeding can ooze out. In a normal child, we would just, hold pressure, give them a popsicle, whatever, and the pressure and the coolness would stop the bleeding. And, over 10 to 20 minutes, the body would make a clot and we'd be fine. With hemophilia, depending on whether they just have limited clotting disorders or limited clotting ability or no clotting ability whatsoever, they either take a long time to clot, or they won't clot at all on their own. So typically what we do is direct pressure, if possible, to stop or slow the bleeding. And all we're doing at that point in time is exceeding capillary pressure so that blood can't get through and leak out, but we're not actually creating a clot or stopping the bleeding in terms of a long-term solution. And then the specific deficient factors need to be replaced. So depending on what it is that they're lacking, we would replace those clotting factors. For people who have a factor 8 deficiency, so hemophilia A and type 1 von Willebrand's disease, there's actually a drug called desmopressin, and you guys probably have heard of desmopressin before. Because it's also used for, it's DDAVP that's used for things like problems with bedwetting and like SIADH. So DDAVP is a drug that can be used to decrease urination, but at the same time it also there's a little blurb about it on page 426. It's a synthetic posterior pituitary hormone. It also stimulates the release of factor VIII and tissue plasminogen activator. So in patients who have the hemophilia A or von Willebrand, they can actually create a platelet clot and stop bleeding. Desmopressin is contraindicated in people who have an allergy to it, obviously, and those with nephrogenic diabetes insipidus, so people who have a problem with their kidneys. And it's available as a tab, which we wouldn't use in this case, but then also injectable and intranasal spray. And then the tab and the nasal spray can be used for nocturnal enuresis, and the nasal spray and the injectable tend to be used for the DI. I think I said SIADH before, but the DI. So if they have diabetes insipidus, it stops the extra urination. So other things that you should know. So obviously, if they're at risk for bleeding, we wouldn't give them other drugs then that would increase the risk of bleeding. So if they have pain, headaches and stuff, we would tell them to take Tylenol, or even opiates are safe. But these patients wouldn't get aspirin or NSAIDs because that would decrease the platelet aggregation and further increase the risk of bleeding. So that's pretty much it as far as hemophilia goes, but it's not on the quiz. It's just I can't figure out where in the book we're supposed to be reading about it in pharm, because it used to be in the chapter, and then with this update of the book it seems to have disappeared. So I think that that's actually the problem. Okay, so let's go through chapter 54 and the information about the anemias. So this is kind of following where we were in P&P. So, you can kind of go through the concept map that we created, but starting on page 863 with erythropoietin, epoetin alpha, which is epogen and procrit, is a biosynthetic form of the natural hormone erythropoietin, and that is the hormone that stimulates the bone marrow to produce new red blood cells, right? It's primarily used to treat anemia, like end-stage renal disease, chemotherapy, and there's a longer-acting form of this also. So darbepoetin is available. The only benefit to that, because it costs so much money, is that you don't have to get so many injections. But like when you kind of put it together, like erythropoietin is less expensive but more injections versus darbepoetin is more expensive but fewer injections, in the long run the cost is the same to the patient. But if you're worried about other things, like if they have really low platelets and you're worried about bleeding, or if they just are in a lot of pain and they can't tolerate the injections, then darbepoetin would be a better choice for that patient. Contraindications for any of the erythropoiesis stimulating drugs, so the epogen, the procrit, or the darbepoetin, which is Erasnep, would be a known allergy, obviously. Uncontrolled hypertension, because adding more red blood cells would increase the viscosity and therefore the blood pressure. If their hemoglobin levels are greater than 10 for cancer patients or greater than 11 for renal patients, then there's not a, it would be harmful rather than helpful to add more. If they have head or neck cancers, adding additional red blood cells increases the risk for thrombus and therefore stroke. And there are some pretty severe side effects with the erythropoietin drugs. And the most frequent ones are hypertension, fever, headache, pruritus, which is that itchy skin, rash, nausea, vomiting, joint aches, and injection site reactions. Iron, there's a lot of questions on iron. So iron is, we talked about, it's a mineral, it is a metal, and it's essential for requiring oxygen, or for carrying oxygen. It's required to carry the oxygen. The hemoglobin binds to it, and the body can't make red blood cells correctly without it. So there's different iron preps that are discussed in your book. Really the most important thing with any of these anemias is first you have to identify the cause. You can't treat it unless you know what the cause is, because if you treat with any of these things without knowing what type of anemia the person actually has, you can mask the signs or symptoms of the actual anemia or the problem. So we talked about with iron deficiency anemia, the primary cause of that actually was GI bleeding. So identify the cause, and then the treatment is aimed at attempting to, first of all, correct the cause. So if it's chronic blood loss, like a GI bleed or cancer or Crohn's disease, it's better to fix it than just try to throw iron at it. Contraindications to the use of iron would be allergies to it. If the person has hemochromatosis, which is iron overload, hemolytic anemia, and that's huge, right? Because if I'm putting iron into a person who does not have iron deficiency anemia, but they have hemolytic anemia, then I'm just going to be dumping tons of iron into the bloodstream every time the body lyses those new red blood cells. And that's going to make the person really sick. Okay, so any anemia that is not truly an iron deficiency anemia would be a contraindication to giving somebody iron supplementation. Most of the side effects or adverse effects of iron supplementation are GI, because the body doesn't handle iron very well. So nausea, vomiting, diarrhea or constipation, either one, stomach cramps, and stomach pain are the most common ones. We talked in class about the fact that they'll get dark colored tarry stools. This book is calling them black tarry stools, but we know, in practice that it's more likely that they're going to get a dark brown or green tarry stool really than black, but the right answer on these quizzes is going to be black, because that's what this book picked. Vomiting, diarrhea, and then the other thing is that iron stains your teeth. So if you're doing a liquid iron replacement, because they have it in a liquid form, you get a discolored tooth enamel as well. Other things that you want to think about is the iron tabs cannot be crushed, split, or broken up. Most of them have some sort of an enteric coating on them to protect the stomach because of all the GI kind of upset. So usually we have people take them on an empty stomach, but not everybody can tolerate that, right? So instruct the patient to dilute oral liquid iron per the manufacturer's instructions, maybe with something like orange juice, right? Because that's going to increase absorption, definitely not with milk. And slip it through a plastic straw so that they don't discolor their tooth enamel. Drink plenty of fluids, but not antacids or milk. Most individuals are going to find that they do need to take oral iron products with meals or food because of the GI upset. So you can tell them to take it with food or even with just a small snack, and then remain upright for at least 30 minutes after taking oral iron to decrease like esophageal irritation. Okay, their stools are going to turn brown to, again, that dark green or black tarry stools, and that's normal, and it's from the iron. And if you think about like with the GI bleed, we've got the iron in the stool that's, you know, causing it to turn black and tarry. So it makes sense that when you take iron supplementation that it would look similar. If a patient can't tolerate oral iron, we do have injectable iron. We have both intravenous and intramuscular doses of iron. If we use iron dextran, which is kind of the oldest injectable form of iron, we have to worry about anaphylaxis and significant orthostatic hypotension. So we use a test dose of 25 milligrams, and then we wait an hour. So they get an IM dose of like 25 milligrams, and then we wait an hour to see whether or not they can tolerate it. And then after the hour, if they don't have a reaction, then we'll give them the rest. Because we expect significant orthostatic hypotension and fatal anaphylaxis, we're going to have epinephrine, Benadryl, and steroids on hand anytime we administer iron dextran. If you give it intramuscularly rather than IV, you do decrease the risk of anaphylaxis. When you give iron intramuscularly, because it's so irritating, you need to use the Z-track method and give it deep IM. And if you give it IV, it can only be mixed with normal saline. It can't be mixed with any dextrose or potassium or anything else. Iron sucrose is a newer injectable that has a much lower rate of anaphylaxis. It's also used for iron deficiency anemia, and it's good for patients who have renal disease. Hypotension is the most common adverse effect, and specifically if it's given in a large dose or rapidly to low-weight older adults. And there is actually a new formulation of iron sucrose where we can give it undiluted over 1 minute IV push. Because we're giving iron for iron deficiency anemia, when you're evaluating your patient outcomes, you want to be thinking about do they have an improved nutritional status? Are they gaining weight? Do they have an increased activity tolerance? Because remember, anemia means I can't get oxygen to my red blood cells. So I have that pallor, lethargy, fatigue, decreased activity tolerance, increased work of breathing, dyspnea on exertion, right? So do I have an increased activity tolerance? Do I feel good? And is there a decrease in fatigue? Cubby. With folic acid, then folic is again a B vitamin, and it's primarily used to prevent and treat folic acid deficiency. Again, it should only be used for folic acid deficiency anemias. So if the patient is anemic, we need to know what type of anemia it is first, because it will mask the signs and symptoms of B12 deficiency or pernicious anemia. If you give it to somebody, you know, it'll make the CBC look normal if you give it to somebody who has a B12 deficiency. So folic acid is also used to support and enhance fetal development. So it provides some prevention of neural tube defects such as spina bifida, anencephaly, and encephalocele. So we recommend that moms-to-be start taking it at least 1 month before pregnancy and continue through early pregnancy to reduce the risk of fetal neural tube defects. And most OB physicians recommend even further than that, like long before and all the way through the pregnancy. And then vitamin B12 actually isn't covered in this chapter. It's covered in the prior chapter, in chapter 53, under vitamins. So, go figure. But you know that it's required for red blood cell synthesis. It can be given orally, sublingually, or intranasally for B12 deficiencies. And then sub-Q or IM for pernicious anemia. And remember, with pernicious anemia, that's the one, you know, we start to see the neurological side effects. So one of our other outcomes is to talk about the acute iron toxicity in pediatrics. So I mentioned that iron is often enteric coated because it causes GI upset, and so for little kids it looks like candy. And so iron overdose is unfortunately the most common cause of pediatric poisoning death in the United States. It's highly corrosive in the GI mucosa, causing bleeding, and then it also causes metabolic acidosis and hemodynamic instability, so it causes severe hypotension from all of the iron. So treatment is symptomatic and supportive. The first thing we do is try to suck out anything that might be remaining in the stomach, and then try to flush out the GI system. We protect the airway. I'll correct the acidosis. So this might be somebody that would get something like sodium bicarbonate. Control shock and dehydration with IV fluids. They might get a blood transfusion, oxygen, vasopressors. And then in patients who have severe symptoms, which would be like seizure, coma, shock, they get chelation therapy. So chelation therapy, we use deferoxamine, or they just approved a new drug called deferriprone, and both of those can be used. What it basically does is it binds with the iron in the body and helps the body clear it so that the iron can't enact its properties on the body while it's in circulation. And then last but not least, but flipping back to page 751, let's talk about our hemopoietic growth factors. So our hemopoietic drugs cover erythropoietic drugs, so epoetin alpha and darbepoetin alpha. So that would be our epogen, our procrit, and our darbepoetin. Our colony stimulating factors, so our filgrastim, our pegfilgrastim, and sargramostim, and then the two platelet promoting drugs, which are oprelvicin and romiplostim. So basically all of these drugs work to stimulate the bone marrow in some way, those stem cells in some way, to create either red blood cells, white blood cells, or platelets. Okay. So all hemopoietic drugs basically have the same mechanism of action. They decrease the duration of chemotherapy-induced anemia, neutropenia, and thrombocytopenia, right? So pancytopenia. They enable then the physician to use higher doses of chemotherapy because we can replace those cells at a faster rate. They decrease bone marrow recovery time after transplant or radiation therapy by making bone marrow more effective, and they stimulate the immune system to fight off cancer cells, viruses, fungus, things like that. So any bad cells that are there, they stimulate the immune system to work better. So all of that sounds really great, right? So let's talk about some of these. So epoetin alpha is the synthetic derivative of erythropoietin. which is normally produced by the kidney and tells the bone marrow to produce red blood cells. Darbepoetin alpha is the longer acting. They are both only available for injection. There's no pill, right? So these are shots only, or IV. The most common adverse effects of all these types of drugs are edema, anorexia, nausea, vomiting, diarrhea, hair loss, rash, itching, cough, shortness of breath, sore throat, fever, some sort of strange blood dyscrasia, headache, and bone pain. Okay, so table 47-1 on page 752, those should be things that you should be familiar with. So we got a lot of patients out there that get these meds, and we need to know, like, is it the cancer, is it the chemo, or is it the hematopoietic drug that's causing the problem when they have symptoms? So filgrastim and sargramostim, so these are both white blood cell colony stimulating factors, have significant drug interactions when they're given with myelosuppressive antineoplastic drugs. So cancer chemo drugs that suppress the bone marrow. And normally what happens, you give these chemo drugs and they suppress the bone marrow so that the bone marrow does not make new cancer cells, right? So let's say you have somebody that has like leukemia. So if the myelosuppressive antineoplastic drugs are given with them, the drugs work directly against each other because the filgrastim and the sargramostim work directly opposite of the chemo. So both of those drugs have to be given in 24 hours, either before or after chemo. And that's typically true of all of these hematopoietic drugs. We don't give them 24 hours in the 24-hour time frame before or after chemotherapy. So filgrastim, I don't know why I can't say that today, is Neupogen, and that's the synthetic analog of the human granulocyte colony stimulating factor. It basically signals the body to create more leukocytes, so monocytes, macrophages, and mature neutrophils, which is great because then they can fight off infection. Neupogen is used to prevent or treat febrile neutropenia, so somebody who has a very low neutrophil count with a fever, and patients who are receiving myelosuppressive antineoplastics, so if they're getting chemotherapy that's suppressing the bone marrow. It must be given before a patient develops an infection, but not within 24 hours before or after the chemotherapy. Leucine, which is sargramostim, is another white blood cell stimulating medication, and this one is indicated for promoting bone marrow recovery after a bone marrow transplant, and used for like leukemia and lymphoma. And then Numega is a hematopoietic drug. It's also considered an interleukin, and it's used for stimulation of platelet growth. And that's the oprelvicin. So that's what I wanted to touch on with those. So just, look when you're taking your quiz, make sure you have 751 to 753 marked, as well as chapter 54. All right, good luck.